The summer of 2024 brought one of the most sweeping enforcement actions in the history of American healthcare oversight, the Department of Justice's National Healthcare Fraud Takedown. In a single coordinated sweep across 50 federal districts and involving 12 state attorneys general, authorities charged 324 defendants, including 96 licensed medical professionals, with schemes that collectively aimed to extract more than $14.6 billion from public and private health programs. The scale alone marked a record, more than doubling previous highs, yet the numbers told only part of the story. Beneath the headlines lay a quieter, more persistent question. What invisible architecture of incentives and sympathies allows such predation to flourish, even as those who perpetrate it often regard themselves as acting within the bounds of reasonable self-interest? Adam Smith, in his inquiry into the principles that govern human moral judgments, observed that individuals naturally judge their own conduct through the lens of an imagined impartial spectator, a figure whose approval they seek, even in solitude. This internal tribunal, he argued, tempers raw self-regard, aligning personal pursuits with broader social harmony. Yet when the spectator's gaze is clouded by distance, by shared interest, or by the subtle reshaping of what counts as virtuous, the mechanism falters. In the sprawling apparatus of modern healthcare billing, that spectator often appears absent or complicit. Providers, marketers, and intermediaries submit claims for services never rendered, unnecessary, or actively harmful, while the programs footing the bill, Medicare, Medicaid, TRICARE, remain abstract entities, distant from the immediate circle of sympathy. The patient, frequently elderly, disabled, or vulnerable, becomes a conduit rather than a person whose suffering registers as a moral constraint. Consider the amniotic allograft schemes that surfaced repeatedly in the takedown. In Arizona, nurse practitioners and sales representatives targeted hospice patients and the elderly, applying expensive wound grafts to superficial injuries, often without physician oversight or genuine medical need. Kickbacks flowed to recruiters who procured the allografts, while Medicare dispersed hundreds of millions before audits caught the pattern. One case alone involved over $600 million paid out of $1 billion billed. The practitioners involved could frame their actions as entrepreneurial responses to market opportunities. A product existed, reimbursement codes permitted payment, and patients received some intervention. Yet the impartial spectator, if summoned without prejudice, would see the asymmetry clearly. The gain accrued to a narrow circle of providers and middlemen, while the cost diffused across taxpayers and the integrity of a system meant to sustain care for the most fragile. Smith's sympathy extends most readily to those proximate and visible. Here, the victims were remote, their losses aggregated into impersonal budget lines, rendering moral restraint weak.
Elsewhere, transnational networks exploited the same perceptual distance on a vaster scale. In Operation Gold Rush, the centerpiece of the takedown, a Russia-based criminal organization allegedly used straw owners to acquire dozens of U.S. medical supply companies, then submitted more than $10.6 billion in fraudulent claims for durable medical equipment, urinary catheters and braces, using stolen identities of over 1 million Americans. Medicare paid only about $42 million before analytics halted the flood, but the intended extraction dwarfed most prior cases. The architects operated from afar, insulated from the human consequences. No bedside encounters, no visible suffering. Smith's framework reveals the danger. Without an effective, impartial spectator bridging the geographic and institutional gap, self-interest expands unchecked, guided only by calculation, rather than approbation or shame. Kickbacks and referral schemes further eroded the moral tether. Marketers paid runners to deliver patients to substance abuse clinics or hospices where care was substandard or non-existent, yet claims flowed freely. In one Arizona instance, a housing company owner received nearly $740,000 in kickbacks for steering vulnerable individuals, often homeless or Native American, into treatment centers that billed Arizona's Medicaid program $1.58 million improperly. The referrer could rationalize the transaction as mutual benefit. Housing provided, treatment funded, everyone compensated. But the spectator, who weighs the patient's dignity against the arranger's profit, sees distortion. Smith noted that sympathy diminishes with social distance. When the chain of intermediaries lengthens, the human cost fades from view, allowing actions that would repel in closer proximity. Even licensed professionals, doctors signing unnecessary genetic testing orders, nurse practitioners applying grafts on command, operated in environments where professional norms bent under financial pressure. Telemedicine prescriptions flowed without examinations. False diagnoses justified high reimbursement tests, all while the physician could maintain a private narrative of necessity or innovation. Smith's impartial spectator demands consistency. Would the same conduct bear scrutiny if performed openly before peers or patients? In many cases, concealment, through shell companies, nominee owners, or falsified records, signaled awareness that the conduct would fail the test. The enforcement response itself exposed structural asymmetries. Federal strike forces, armed with data analytics, seized over $245 million in assets, cash, cryptocurrency, luxury vehicles, while preventing far larger payouts. Yet the takedown, though record-setting, addressed only a fraction of systemic vulnerability. Programs like Medicare remain attractive targets precisely because payments precede rigorous verification, and the political economy rewards volume over scrutiny. Regulators face resource constraints. Offenders exploit asymmetries in information and enforcement power. Those who absorb the damage, the taxpayers funding the programs, the patients receiving substandard or sham care, rarely possess equivalent leverage to demand accountability. In the end, the 2025 takedown clarified a persistent architecture. Power resides in the ability to obscure moral distance, to diffuse costs while concentrating gains, and to operate where sympathy fails to reach. The impartial spectator, when institutionally weakened, cannot reliably restrain self-interest. Those who profited most strengthened their position through evasion and scale. The system, though bruised, adapted with new tools like data fusion centers. Yet the precedent endures. Unchecked hierarchies of liquidity and influence quietly reinforce themselves, while the diffuse many bear the quiet, cumulative weight. The question lingers, not whether such predation will recur, but how deeply the spectator must be embedded to prevent it from becoming routine.
While Medicare dispersed hundreds